We had one of our customers in Australia sent us an email saying, Boostlingo, you helped save a patient's life today. And this was a very rare language. It was the middle of the night, and through our technology and our resource pool, 17,000 interpreters, we were able to connect the right interpreter for this very challenging, patient. And that discussion was critical to help save that patient's life. And we were lucky. There was an interpreter available. What if there wasn't one? Like, if that alternative is nothing or an AI interpreter, there are going to be some of those in the future where using AI would make sense versus nothing. I'm a nurse by background, and so I started my career running transplants in an academic medical facility many years ago. And one of the things that really intrigued me when I was practicing was really healthcare was very manual. Like, there was no electronic medical record. Charts had very sick patients. Charts were many and deep. Even the supply chain was very manual. And so I became very interested in how do you bring some efficiency into healthcare. Unfortunately, one of the things that kind of catalyzed that for me is that we had a sentinel event with a patient. The patient died, and part of the breakdown in care delivery was related to information. This patient went to surgery and probably should not have been going to surgery, shouldn't have gotten a liver transplant, had contraindications for success. And during that procedure, also, we had a breakdown in supply chain. And so the outcome for that patient was devastating. Now, this was a terminally ill patient, but it was also equally devastating for the care team, because these are excellent care team providers, excellent doctors and nurses, and really the system was not built to really support them in the delivery of care. And so I kind of took that and made that a focus of mine in graduate school. I focused on information technology. How do we automate practice delivery? How do we capture the appropriate information so that it's readily available? I did my thesis work in that in graduate school. And coming out of that, I ended up at a healthcare tech company. And I thought I would go for a year, learn a little bit about the tech side of the industry, and then it's turned into a career. Healthcare delivery in the U.S. is very complicated. It's probably one of the most complex businesses that we have. The cost of it is really astronomical. In 23, we spent $4.9 trillion on healthcare delivery. Okay, 4.9. That was up in 23, 7.5% year over year, which is also kind of stunning, that type of growth and spend. The government, which is Medicare and Medicaid, provided services, paid 1.6 trillion of that 4.9 million in healthcare spend. It's about 24% of our GDP from a government perspective. So Social Security is 21%, healthcare leads the pack in spend at 24%, and the defense is 13%. So it gives you a little bit of perspective of how much money is spent in healthcare. And so when you look at that spend, every man, woman, and child in the U.S. is being $14,000 plus are being spent to take care of those Americans, right? That's really kind of astronomical. So that's really not sustainable from a growth perspective, and it's not sustainable from a country perspective. We have to do something about the incredible cost of healthcare delivery. And so that's been a kind of a passion of mine, and it's also been a focus, I think, within several administrations on how to address and how to kind of bend this cost curve. When you look at the U.S. in particular, we're spending 24% GDP on healthcare. If you look at the rest of the first world nations, the top spend is about 10%. The rest of them are spending less than that. So we're more than double what other first world countries are spending in healthcare. And why is that so? And I think it's multifactorial. It's because we have a incredibly complicated delivery system. We have multiple payers in the mix. We have a history that's also led itself to some of this complexity. We have deserts of care where access is just simply not there. We have socioeconomic really barriers to care as well. And we really have a care delivery system that's focused on managing disease and not really managing wellness and health. And so all of that, I think, lends itself to a really complicated and costly healthcare delivery system in the U.S. To talk about value-based purchasing or value-based care, I think it's important you really understand how we got here. This just didn't happen overnight. And what problems are we trying to solve with value-based purchasing or value-based care? So a little bit of a history walk back. In 1965, the Johnson administration formed CMS, or Medicaid services, Medicare services, to really provide health care to Americans who were uninsured. And for many decades, until 1983, if you got health care and you were under Medicare, or really any other, if you were private pay, you would see your provider, you'd go to the hospital, any service that was ordered, any care that was delivered, the payer, which would be Medicare, or the private, would just do a retrospective cost reimbursement. So it didn't really matter that there was limited budget, or that the government couldn't pay just exorbitant fees. So if you could charge anything you want and do all the testing that you wanted and all the care that you wanted to deliver, then hospital costs and healthcare costs went up dramatically. In 1983, there was an attempt by, and we're still under this system, by CMS, which is the Centers for Medicare Services, Medicare and Medicaid now, services, put in the prospective payment system. That prospective payment system said, wait, there's actually a cap that we're going to reimburse you for these diagnostic or diagnosis-related groups. So if you have, hypertension, then this is what we're going to reimburse you for that level of service. And so it really capped down kind of that reimbursement. It was just not unlimited. And so we're still in that payment system today with caps. Unfortunately, though, when you look at the GDP spend in healthcare, even from 1983 to today, and I think way back then it was 15% GDP. It's now at 24, moving to 25% of GDP. The prospective payment system has not addressed really this ballooning cost infrastructure of the delivery of care. 2003. There was CMS, which is again the Center for Medicare and Medicaid Services, did a demonstration project. They had this idea: if we pay for quality and better outcomes and better cost structure, if we incentivize hospitals, would we get a better result? So they took 250 hospitals, they agreed to participate, and what they showed was significantly better quality and lower cost in this incentive demonstration project. And so that was really the beginning of value-based care, going, okay, if you pay for better quality, you can get it. And then there's been a number of legislations that have moved that continuum. 2009, the Obama administration did two major pieces of legislation. The first was the American Recovery and Reinvestment Act in 2009. What it did, it was a big omnibus spending bill, but what it did, it had a provision within it, which was the HITECH Act. And the HITECH Act basically said you have to put in an electronic medical record and capture the care delivery process electronically, and made that a mandate. And so that's when you saw physician practices and hospitals really taking up EHRs in droves, or electronic medical records in droves. And it did some really great things. It did things like put barcodes at the point of scanning for medications. It took the written physician order, which was impossible to read, and made it electronic. So it helped in quality, but it didn't really address the dream of improving kind of the efficiency and the cost reduction. And that was one of the promises that the HITECH Act did not do. But it did create a data lake. Now we know what care is being delivered, and we can measure it and report it and analyze it. And so many good things have come because of that. Well, right after the ARA in 2009, the Obama administration passed the ACA. And that act in 2010 actually expanded, and that's the Affordable Care Act, or you'll hear it Obamacare. That expanded Medicare and Medicaid services, greatly expanded it. It created the insurance exchanges, so we still have those today. It created non-discrimination, so making sure that people have equal access and right, and that has provisions in for language access. So language couldn't be a barrier, that healthcare providers needed to provide language access as part of non-discrimination, and that's under the 1557 section of another omnibus bill. It also had provisions in 2010 for value-based care or value-based purchasing, and it had, but which would not go into effect until 2013. And what it did was it said, we are going to, like the demonstration project back in 2003, we're going to reimburse and pay based on quality, safety, based on cost and efficiency, and based on patient experience. So those four kind of major categories were the basis of how organizations under Medicare, Medicaid could be reimbursed. And so that went into effect in 2013 and was actually looking back at historic performance. So as you were going from 2010 to 2013, you were being measured for how you're performing in quality, efficiency, cost, safety, and then you were reimbursed next to that historic performance. So that's been in place since 2013, and the reason it went into place and the reason we did the demonstration project was to try to bend that cost curve. And so if you looked at the graph, healthcare spend versus everyone else, we're going up and to the right faster as a nation, and the delta between, again, 10% versus 24%, now moving to 25%, is not sustainable. And so trying to reduce the cost, get better quality outcomes, that's been the basis of value-based purchasing, hence value-based care. Really important and critical that we look at LEP patients as a cohort under value-based care. We don't today. So when we go back again, the measures for value-based care, the big categories, quality, patient experience, right, safety, cost and efficiency, those are equally important for LEP patients that most likely are having gaps because we already know that about 66% of the time, there's clinical conversations that are happening without an interpreter. And so we're not looking at those outcomes of them as a cohort. There's been some studies, and the studies show that there are gaps, and then there's always the big areas where there's been a major sentinel event that gets a lot of press, and you can tie it back to lack of language access. But I would put it to the people that are in quality and the healthcare delivery systems today that we need to look at not just the value-based care measures, but all the measures that we publish, we study, and look at their observed to expected ratio. And that's a very common metric for quality leaders. So the chief quality officer, the chief medical officer, very familiar with that, intimately familiar, that we need to look at that observed versus expected outcome to the general population versus patients that we know are designated as limited English proficient patients, and see where we have the gaps and where we have the gaps in quality and safety and efficiency, because I feel confident that they're there, but we are not doing that systemically as a country. And we've done limited studies, like NIH has done some studies, but that needs to be part of the reporting metrics that our quality teams do. It starts at the organizational level. There's so many hospitals, really leaders in quality. They publish their quality reports online. You can go to the websites, you can see their the detailed quality reports. I looked at one just today, and it was good to see it. And it was what happened to be a health system that I knew was an innovator in quality, and they're very transparent. But there's no data in there about how care is being delivered and the outcomes of that care, the cost of that care for LEP patients, and there needs to be. And I think until we start doing that, till we have that data lake, like we did with just getting everyone on an EHR, then we have that data lake of information on LEP patients, then we'll understand where the gaps are and how language access can solve that. But if you think about things like readmission, right? You need to understand your healthcare plan. What if, when I leave a healthcare provider, what do I need to do to make sure that I'm staying on treatment without, an interpreter to help explain, to make sure that that patient understands, when do I call, when do I come in, for example. That's just one of many. Do I go to an emergency room, right? What do I need to report on, right? I need to understand all of that as a patient at a detailed level, and that sometimes is missed, and we're not measuring that. But we have the cohort data, we can, and that's really one of the charges, and one of the things I would love to see happen in the industry, and I think that needs to be a partnership with companies like Boostlingo that are providing language access, and with the quality departments and quality leaders in healthcare. You can take any of these metrics, like readmission, right? Just the readmission rate, which is negative for a healthcare provider to have higher readmission rates. What is that in your LEP population, your observed versus expected, next to your general population? What are your patient experience scores of your LEP patient population versus the rest of the general population? That observed versus expected. Are they better? Are they worse? What's your mortality, right? All-cause mortality, risk adjusted, of your LEP patients versus the rest of your population, patient population. Do you see deltas? Because I think that would be very revealing, and the data, there are snippets of this data, there are studies of this data, but there's not a consistent reporting of this because quality departments aren't doing that. They should be. And we would understand the delta, and then how do you solve that? And do you solve that with better communication? Are they in a healthcare, kind of desert, right? Is there more community outreach, and you're doing that in conjunction with interpreting services to really address those healthcare gaps and needs. So again, data should drive all of this, and the data organizations have. They know their LEP patients, they know their quality scores, they're reporting it under value-based care. It would be a simple process just to take that patient populations that are LEP and cohort that patient population. I think that really doing integration with EHRs is table stakes. We have to do it. When you look at every provider today, they're mandated to have an EHR. It's not necessarily driving efficiency. That was the promise, but not delivered of an electronic medical record. But it is doing data capture, and they're required to do it. And it gives us that, again, data lake of what's happening across care delivery. So the integrations need to be thoughtful, and workflow matters. And so, simple things like a deep link is probably not really the ultimate workflow that's going to address some of the efficiencies that healthcare providers need. Writing back to an EHR, really impactful. There's no human in the middle of that. It just is a matter of fact, this service was provided, I met requirements under 1557, requirements for providing language access, and it's just a byproduct of me doing my work, or embedding it into a telehealth applications where I can just simply pull up an interpreter as part of my natural workflow. These are deep integrations that don't disrupt my natural course of the way that I want to conduct my time with my patient. And so I think we need to be thoughtful in how we deliver it. And I think it's not just, hey, you can link out and jump into our system, and if I'm documenting, and then I'm going to overlay this link on top of my documentation, well, you've completely disrupted my workflow. And so we need to be thoughtful in how we deliver it, and also thoughtful when we say that integration may not be the best workflow, and maybe a different type of workflow should be considered. So maybe even a different device. So all of those I think we need to take in consideration. But to me, understanding that workflow and integrating into that workflow is just going to be table stakes for language access. I think it's just a requirement. And again, providers are busy. Care team members are incredibly busy, and they want those efficiencies. And if we can save them a step by integrating and having that interpreter available on demand very quickly and engage within just seconds within their natural workflow, that's a win. Back to the inefficiencies of the EHR, right? The promise of we're going to get productivity, that didn't happen. The promise of AI is that those productivity gains will happen. And if you think about healthcare and the margins that are in healthcare, 3%, 5% margins, very, very tight. Getting those efficiency is really critical. And so I think AI is going to, in many facets, be integrated within healthcare. It's already happening. Physicians are talking, and the notes being written today through AI. I've seen some AI that's doing scheduling, which is an administrative task. There's AI today in clinical decision support, like what is your treatment plan, with diagnosis, etc. So, that's very invasive AI, right? So I think it's inevitable that AI interpreting is going to be part of the solution in healthcare. I don't think it will ever be all of the solution. I think there will be use cases that make sense for AI and use cases that absolutely don't make sense for AI. If we have a patient clinician relationship, and I'm talking to you about a very challenging diagnosis, right? Of you, of a family member. No one wants an AI interpreter in the middle of that discussion. That is not an appropriate use case. If I'm trying to get directions, right, or if I need water, you know, I've got the nurse call system and I need someone to help turn me in the bed. And those are happening today without an interpreter. And so there are gaps in communication. I think those are the types of use cases that we will see AI scheduling, that will, you know, we'll see AI come in and start playing a role. I think we will start to see some use cases, yes, starting this year, and it will be limited, and it will be mostly administrative. But you know, just about a year ago, we had one of our customers in Australia sent us an email saying, you know, Boostlingo, you helped save a patient's life today. And this was a very rare language. It was the middle of the night, and through our technology and our resource pool, 17,000 interpreters, we were able to connect the right interpreter for this very challenging, you know, patient. And that discussion was critical to help save that patient's life. And we were lucky. There was an interpreter available. What if there wasn't one? Like, if that alternative is nothing or an AI interpreter, there are going to be some of those in the future where using AI would make sense versus nothing.